Hello, I'm Dr. Jessica Young, and I want to thank the conference organisers for their wonderful job, and to the New Zealand End of Life Choice Society for sponsoring my trip here today. So the title of this talk came from a meeting with the Ministry of Health policy team who were looking after the review, when we asked them about what sort of data they wanted from us as a research team, and they wanted experience, evidence and expert views. So I hope to share some of that with you today. Gary's already nicely outlined the procedure, so I'm going to start with some statistics and then get stuck into two research projects that I've been working on. Right, don't worry about this table, I'm going to run you through it. So of the 834 applications that were received over the 23-24 year, 82% were New Zealand European, 4% identified as Māori, the Indigenous people of New Zealand, whereas they actually represent 12.5% of all deaths, so very underrepresented. 78% were 65 years and older, 69% had a diagnosis of cancer, 76% were receiving palliative care at the time of application, and 12% reported a disability at the time of application. So we actually don't know about the demographics of the people who go on to receive assisted dying, but we do know that of the applicants who were assessed, 19% were found ineligible at that first assessment. 2% were then found ineligible at the second assessment or the final discussion. 4% decided to withdraw their application. 6% lost competence in the process. 1% lost their eligibility. 1 person was found ineligible at the final review by the registrar who checks for compliance. And 28% died in process, which leaves 38% of people who applied to die by assisted dying. So that's 344 people in the last year, which is up from the 257 deaths in the first year of the service. 92% of people opt for the IV route rather than not self-administered administration. 80% die in a private residence, 10% in an aged care facility, 2% in the single hospice that allows assisted dying to occur on site, and we'll hear from their chief executive tomorrow. And for those who are found eligible, the average application time takes 16 days. So the first study that I want to share with you is the post-doctoral study that I undertook. We have a date-setting process, which Gary has touched on. So we have to set a date for usually the doctor, but sometimes a nurse practitioner, to turn up with the medication, whether you're self-administering or whether that's going to be administered to you. Now, of course, you can change that date, but any date changes are subject to a 48-hour approval process period, and that does not include the weekend or public holidays. But to note that there are no other waiting times in our process. So here's a complicated table to tell you that we interviewed 7 patients, 10 family members, and 6 assisted dying providers who were looking after those 10 cases. We did multiple interviews with people and tried to have a longitudinal approach to interview them in the lead up to the assisted death and afterwards. The patients were all people that had cancer, as we were sponsored by the Cancer Society. So when we looked into the data, we identified 4 decision-making phases, and I'll run you through these. The first one was deciding how and when to draw a line in the sand. Now that metaphor, of course, can be washed away by a wave coming at any time, but being asked to set a date was described as confronting by both patients and family, because it required them to commit to a time frame for assisted dying, but also as well as producing uncertainty about when the right time would be. But once the date was set, the patients and families described it as a great sense of relief or peace of mind, or others described it as this looming countdown that felt really weird or really uncomfortable. Depending on how far out the date was set, some people felt like their life was on hold, or the relatives felt like their life was on hold and they needed to manage their own time and personal commitments. During the final countdown, the job of the assisted dying provider was to liaise with patients and families about how that date was sitting with them, but they didn't want to do that too often so as to be seen to be putting pressure on the patient. The day rolls around, and the patient's focus is on saying goodbyes and saying their final words. And the families and the providers are really interested in this relationship management, who's in the room, who's in the house, who's looking after the children. But having the date meant that they could plan for all of those things. And as one family member described it, they could curate the moment or create that experience. One patient used the phrase, "How long is a piece of string?" to discuss trying to guess at something that cannot actually be measured, namely how long you have left, when your date with death should be, or the right time. Patients experienced an embodied or a physical sense of when the right time for them would be. And there was this shared belief among participant triads, or the patient, family, and provider, that there was a right time for a date with death. So, picking a date for assisted dying is an embodied or physical decision. It is a relational decision made between this triad of people. It is situational, so it shifts in response to the evolving situation. It balances people's needs, and it is in response to the regulatory systems which dictate the date-setting process. It is an existentially, socially, and clinically difficult decision about a date for death that can be made and sometimes remade, and it's made to balance the time left and the quality of that time left. So living with and anticipating a date brings new meanings to the time that remains and to time as a construct. So there is a certainty that comes with having a date, but it also introduces new uncertainty of, is this the right date? Will I live to the date? So with the caveat that a date could indeed be left too late and that the person might die beforehand, espousing that the death took place at the right time appears to be a means for making sense of this new way of dying, of a planned death. The next project that I want to share with you is the biggest national study of assisted dying in New Zealand to date that I'm leading with an excellent team that I'll show you shortly. We've received $1.4 million of funding from our National Health Research Council, and it is a collaboration between these universities. Here's the team. We are a multidisciplinary bunch, and we also are advised by clinicians, Māori disability and academic advisors too. So some of the views that I'll go on to share with you about the findings that we have doesn't necessarily represent the whole team, as we are a mixed bunch of views on assisted dying. But the aim that does bring us together is to inform the assisted dying service, which is dictated by our legislation, so that it is safe, people-centred, dignity-enhancing, accessible, and available equitably to all eligible people. So we're really foregrounding people's lived experiences of using this legislation, providing this legislation, and being proxy to this legislation as a means to improving it. In the first year of the project, which is a 3-year project, we have interviewed 96 people from all sorts of backgrounds, both eligible and ineligible service users, and we've specifically sought those that have impairments to understand the accessibility needs of them and how the service could meet them. We've interviewed relatives whose family members have both completed and not completed assisted dying. We've interviewed assisted dying providers, non-providers, so that can be anyone from a conscientious objector right through to an ally, and we've also talked to health service leaders about how they've gone about implementing this. We're also holding annual focus groups with 2 Māori communities to understand their community responses, issues, discussions over the 3 years of the project. Almost all of these 96 interviews took place online and on average took an hour and a half. So, I was going to tell you that we had some safety and wellbeing protocols in place for participants, so we followed up with everyone the day after the interview. We also had the P4 suicidality screener on hand, and we used it twice, but they declined that they had any suicidal thoughts. We designed the study to be inclusive and accessible, so we wanted to translate the participant information sheet into New Zealand Sign Language video, e-text for screen reader, and to make it into easy read for people with intellectual or learning difficulties. So to delve into some of the data, as we know, assisted dying, conscientious objection is a spectrum for a lot of people. They may have a range of objections to it, and right through to being participants and allies to the service. So we heard about conscientious objectors withholding clinical information which caused delays. But we also heard of much more subtle forms of conscientious objection that I want to share with you. So this is a quote from an ineligible service user who was residing in an aged residential care facility. And he's talking about his general practitioner who cried for half an hour when he told her that he wanted to seek assisted dying. And he said, well, my general practitioner was interviewing me and she was trying to talk me out of it. She didn't talk me out of it. She wasn't against it, or she didn't say she was against it. She was very good. I don't know whether she approved or did not, but she said, oh, that's your decision, that's fine. So she was supportive, put it that way, but she cried for half an hour, end quote. So, was this doctor a conscientious objector? Perhaps, perhaps not, he didn't seem to think so. Was this a case of dissuasion? Or perhaps it might register as coercion. Fortunately, this person was connected with the End of Life Choice Society and who advocated for him. But if undue pressure to seek assisted dying is unacceptable according to the law, how are these cases of dissuasion acceptable? And so the person who conducted the interview, who's a disability law expert, said, although I would not portray this as customary coercion, crying could be portrayed as undue influence, or something to that effect anyway, but it interferes and breaches boundaries and intrudes on autonomy. Of course, we need to keep the conscientious objection provisions within the Act, but the essential duty for this general practitioner to refer this patient to the assisted dying service is enshrined in our law, and that is essential that that referral takes place. And it also needs to have the patient's right to have their request handled appropriately be enshrined in any future legislations too. So the question here is, how prepared is the workforce to handle these requests and to manage their own emotions appropriately? So even when you find cooperative healthcare professionals, there can still be barriers within the system. This is a long quote that I'll try and paraphrase. So the son that we spoke to, his dad was 89 and diagnosed with terminal cancer, and both of his parents were hearing impaired. So the parents saw the GP, who rightly referred him to the assisted dying service, and the service contacts people who apply back. But they don't say who is calling to the person who answers the phone, fine. But then the father, who finally gets the phone call, doesn't understand who's calling. He's got multiple services caring for him at this point. And so he says he's fine, he doesn't need any more care, when in fact he should have verified that he was requesting assisted dying. This actually happens twice, and a month is lost in the process. And so by the time they work out what's happening, the service is actually able to get up really quickly, and he has the 2 assessments, he's found eligible within the space of a few days, but he dies a few days before his date. And so the son described that the communication was very poor and that it needed to be face-to-face via the patient's GP or with a family advisor who's appointed as that communication liaison person. Because if that had happened, they wouldn't have lost all this time and his dad would have been able to die by assisted dying. So this is not just an access issue, but it becomes an equity issue when certain groups are disadvantaged by the design of the system. And it's not just hearing impairment, it's other things like memory impairment, sight, English as a second language, literacy, living rurally, frailty, and just being gravely unwell in general. So this is a policy decision, not a legislative one, that they can't say who is calling. So this might be a case of too much safety. Now, the last issue that I want to touch on is one that incorporates safety, access, and equity. So an eligible service user who was living in the community that we interviewed said about this prohibition that Gary's already touched on, or the gag clause. So my GP can't bring it up, but I wanted to talk to him about it. So we had this strange conversation where everyone knew what we were going to talk about, but no one could talk about it. And I didn't know that I had to bring it up in the way that I needed to. What about all of these communities that aren't really aware of these things? Those communities that don't have access to information, access to healthcare, because you can't clearly advertise it. So we hear, despite having a very public referendum, that the public is not well aware of this service, and this is likely to be more of an issue in communities that are less literate, less well-resourced, and have less access to the internet. So by design, we are embedding inequities into the system by having this prohibition. So, to consider whether the Act is meeting its stated policy goals and values, we need to look at safety, access, and equity, and if the service is delivering on its person-centred and dignity-enhancing goals. And I would say that for the most part it is. But we also need to think about assisted dying in the context of social, structural, economic, relational determinants of health, health literacy, and access to healthcare, and how these factors should be translated into law as a unique focus of our research that we're just starting to explore. Now, it's easy to think of safety and access in opposition. The safeguards stop people from accessing assisted dying. Too much access and people will be put at risk. But I put to you, as others have, that safety and access work together, but that they are mediated by equity. The key to designing and enacting legislation is a balancing act. Rights to safety and rights to access illegal healthcare should be equitably available to people that account for their unique needs and impairments. So the safeguards, while having individual merit, can act together collectively to prohibit people from accessing a legal health service. And piling on more and more safeguards to already sound assisted dying laws does not make laws safer, and in fact it can make them worse or inaccessible. We've identified the need for public and provider education, standardised practice guidelines, relationship building, and we're recommending that we get rid of the prohibition. So I hope our Minister of Health and soon-to-be Ministers of Health in charge of assisted dying legislation can take our experience, expert views and evidence and put them to good use. Thank you.